From the Library of Congress in Washington, D.C.
I would like to welcome Lucy Sudreth, our Chief of Support Operations for the Library of Congress, and she will be introducing our distinguished speaker. So, without further ado, thank you.
Good morning. Good morning. Glad to see those of you who have joined us so far, and welcome as well to today's Health Forum. I'd like to actually start by thanking, though, Dr. Charles and Paul Martin and really the entire Health Services staff for their continued support in making sure that we are aware about important health issues as they not only relate to us, but to the greater community. Today's forum is especially an important informational session as the incidence of HIV/AIDS within the District of Columbia area is at 3 times the national average. Early diagnosis of HIV has a good prognosis given the current advances in treatment protocols, and that's why awareness is so very critical. We're especially pleased to have with us today a renowned physician in her own right, Dr. Mandefro, an Ethiopian-American physician, medical anthropologist, and public health researcher. She currently serves on the faculty at George Washington University School of Public Health and Health Services. Dr. Mandefro has worked with HIV-infected and affected communities, domestically and internationally, for more than a decade. She doesn't look that old, does she? During her internal medicine residency at the Montefiore Hospital, she founded the nonprofit TruthAIDS, focused on improving behavioral health literacy among vulnerable populations. This work is featured in a full-length documentary film on HIV/AIDS and African American women entitled All of Us, which premiered on Showtime Networks in 2008 for World AIDS Day and was recently featured at the library by Health Services. Her interest in improving public health through media was also the focus of her work as a Robert Wood Johnson Health and Society Scholar at the University of Pennsylvania. Dr. Mandefro was recently a White House Fellow in the Obama administration, or I should say with the Obama administration, where she co-authored the first Joint Veterans Affairs and Department of Defense Mental Health Summit Report and recommendations confronting America's 21st century responses to the psychological needs of returning service members and veterans, and that too is touching all of us. She currently serves as an advisor in the strategy group in the Office of the Secretary of Veterans Affairs with a focus on behavioral health policy and health disparities, and she is their representative to the Federal Interagency Health Equity Team. Dr. Mandefro also continues her international work as a member of the Board of Directors for the Reproductive Health Organization and Gender Health. She received both her undergraduate and medical degrees from Harvard University and a Master of Science in the Public Health of Developing Countries from the London School of Hygiene and Tropical Medicine as a Fulbright Scholar. Here at the library, we set a high mark for acquiring, preserving, and providing access to knowledge, and we're pleased to have this physician with us here today to share her knowledge. Please join me in welcoming to the Library of Congress, Dr. Mandefro.
Wow, that was quite an introduction. Thank you for that, and thank you for all of you. It's a treat and it's a real honor and pleasure to come speak here. I've been in communication with your staff and Jean in particular for over a year now, I think, going back and forth. So I'm very excited. I also have to point out my father's in the back row, and he never gets a chance to actually see me speak. So that's my dad in the corner. I actually grew up in this area. So for me, coming back to DC was a totally unexpected thing and a very good thing. This is home for me, so it means even more. Today, I'm going to be talking to you about awareness. But first, I'd like to talk to you about disparities because that's where the bulk of my research is. And I think to understand awareness and to talk about it, we have to understand the epidemic kind of from the top view level. So that's where I'll be starting. Is there a problem with my mic? Can you guys hear me?
We can hear
Okay, I just want to make sure. Thank you. So I'm going to start the presentation by just thinking through what the epidemiology of the epidemic actually looks like in the Black community, which is where I've done most of my work. I've also worked in Kenya, South Africa, and Ethiopia. And I'll touch a little bit on global disparities, but I kind of want to focus top level on what those numbers are because I think it very much sets the frame for what limits of awareness are. I'll be using CDC data slides, so all of this is on the CDC website. I'm also using a couple of slides from Dr. Valerie Stone at Harvard Medical School, who very kindly shared some of her slides with me. I'll talk a little bit about women of color and youth because lately I've been thinking a lot about the issues of youth. It's kind of a different beast for different reasons. I actually for a short time was an adolescent medicine physician at Children's Hospital Philadelphia and got a firsthand look at what those issues were and wanted to mention that. And towards the end, I'll talk about kind of treatment disparities, but really asking some questions about what the future of all of this means. So, without further ado, this is a history of the epidemic. This is AIDS diagnoses from 1985 to 2008. And the two things to kind of walk away from this slide, if you'll notice, is that we expanded the case definitions for HIV at about 1993, and that led to the expansion of AIDS cases. And then in 1996, that's when we started to have medicines. So you'll notice this decrease right here is right around 96 when we got the antiretroviral therapies. And that slowed the progress of HIV infection moving into AIDS. And so that's why you see the dip in the curve. Now, AIDS diagnosis amongst adolescents and adults by race, you'll note the changing distribution since the beginning of the epidemic. Ooh, I don't know how to use this yet. Ooh, okay. So this yellow line used to be very much a white epidemic in the beginning, and then with time it has risen. So this changing of distribution, these colors will stay relatively consistent through the slides with the pink or purple representing African Americans. Then from about 2005 to 2008, AIDS or HIV infection actually became the largest percentage of that diagnosis, about half the population was in African Americans. So we've been here with this epidemic since at least 2005. In terms of even what the epidemic looks like in the district, it's mostly an African American, disproportionately African Americans with HIV diagnoses. Now, when you subdivide this data a little differently, you'll see actually that this disproportionality holds across subgroups. So when you're looking across all cases of women, you'll notice 64% of women that have HIV infection from 2005 to 2008 were actually also African American. 66 of those infections when you look at it by heterosexual contact. And then one of the most disturbing to me, when you look at of the kids, it's 13 and under. 66% of those kids are Black. Okay, so this is kind of the milieu that led to all of us for me as a researcher. Just by a show of hands, how many of you have seen the film? Just so I know. Okay, so it's about half and half. Thank you. Great, thanks. So when I made that film, I was a first-year resident in the South Bronx, and I had just come back from South Africa and Ethiopia. I had completed my master's work, and I was trying to get my head around what the epidemic looked like in the inner city. My clinic was very much situated. It was actually the poorest urban congressional district in New York, and the clinic was called the Comprehensive Healthcare Clinic in the South Bronx. It's Montefiore is a hospital of Albert Einstein's College of Medicine. And so these numbers were very much my reality, kind of thinking through the epidemic. Now, this pie chart here illustrates the distribution a little differently. The one on the left is the distribution of diagnosis by race and ethnicity, and then the one on the right is the total population. Actually, in the film, I do an exercise like this with the girls, and one thing I'd like you to note is the pink actually or purple here, is the black population. So, makes up 14% just in 37 states if you take it as a total population. But when you look at the burden of infection, 52% of the infection. Now, when you slice the data up differently and you just look at men and women, it continues to be disproportionate. So on your right, 13% compared to 46%. And the other colors is the yellow color is the white population, and the green color is the Latino population. And then when you get to women, this number in particular was kind of what sparked my research. Black women make up 14% of the population in these 37 states, but actually 67% of the disease burden. And when you have such a disparity, it has to make you pause, right? I mean, you have to pause at the very least and start thinking, what is it? What leads to such disproportionality, especially in a country that's so powerful, so fully resourced? In my idealistic kind of eyes at that time, this is now, God, it's been 6 years since I started that film project, maybe almost 7 years. There are doctors there, there are clinics available. What is going on? How do these numbers persist? And, it's 7 years later. I can't tell you the answers are that much clearer to me, but I do know that part of what we have to do is look at it a little differently and try to unlearn some things we've learned. That said, I'd like to also talk to you about rates of infection. So up until this point, I've been showing you kind of individual numbers, individual diagnoses, but in public health and epidemiology, we also talk about rates, right? Which gives you kind of the idea of how fast the epidemic is growing. It's also referred to as incidence, and it's basically looking at, the number of people who develop a disease over a period of time divided by the population numbers, okay? So these are rates, and when you start looking at the rates, this gives you an idea of how fast it's growing. For African, this is for men, it's 131. Compared to a baseline in the white population of 16, and that's about 8 times higher than for whites and 2.5 times higher than for Latinos. Now, when you look at the same, now mind you, these numbers are from 2008, and once again, it's 37 states from the CDC surveillance database. Once you look at women, we have a rate of 56 compared to 2.9, and that's about 19 times higher. So this disease is 19 times more efficient spreading in the lives of Black women. And that was really the backdrop to all of us for me, especially as a primary care physician in a clinic that was giving, free ARV medication. The whole kind of ethos behind my primary care residency, it's a jewel of a program, was really community-based efforts. So these statistics kind of flew in the face of all of that, and I was trying to very much make sense of them. So when you look at this distribution, they actually don't have the District of Columbia up here, annoyingly, but you'll realize that there are hot pockets of infection in the epidemic, even as of today. And why this is important is the epidemic today is a question of density. It's kind of like where you live. If you live in a pocket, your behaviors, it doesn't matter how high risk they are, you're kind of in trouble. And trying to message around that is actually a very difficult thing. So there's a geographical distribution to the epidemic that's also a challenge for communication in my personal opinion. So that said, let's transition a little to the epidemiology of HIV in women's lives, because that's where I focused. The film was shot in New York City, and when you look at these same numbers, what you realize is there's actual geographic variations. Geographic variations is something, it's like a buzzword in healthcare. We talk about that a lot. But there's also kind of geographic variations of wellness and these pockets of infections. And what you'll notice is HIV has been particularly bad in the Northeast, followed by the South. The South's epidemic is actually catching up very quickly. But what you'll note is there's actually less, Montefiore, that Northeast epidemic, New York State has had a bad situation, especially for the Black population, for a very, very long time, which is partly why that film was shot there. This is probably the most important data slide in a way compared to, for the film All of Us, because what this slide shows you is it color codes the transmission categories for HIV. So this is particularly important because when it comes to our federal dollars and spending and prevention programs, we actually tend to do it by transmission category. So if you look at the color codes, you have injection drug use, and then you have heterosexual contact, and then you have other for women, okay? Now, I'm not sure what other means, but when you look at blacks and you look at Latinos and you look at whites, there's a disproportionate rate of heterosexual contact. So in women's lives, that's kind of what it represents, right? And that's why I delved into those issues of interpersonal relationships with the film, and why I think thinking through relationships and messaging around relationships is a very, very important awareness message. We haven't gotten that part quite right yet, and I think it's because we don't have enough messengers telling it in different ways, and we'll kind of delve into that. But, you know, this struck a chord, and it struck a chord in me also because anthropologically, if you think about it, then, well, 75, 84, and 87% isn't that different across the races. But when you start looking at who dies from HIV, it's not quite that equal. So that was the other piece of what I wanted to talk to you about. Now, when you start splitting up the data by age, it actually gets even more extreme. So if you look at risk, heterosexual contact, you'll notice in the older age group, it's about 79. You get younger and younger. In the young group, it's 90.5% of cases come from heterosexual contact. Young girls having sex between those ages, oftentimes with men who are older than them. And that from the jump sets up a very difficult power dynamic. And it's something that I thought we didn't talk enough about. It's partly why at the end of that film I started going into schools, and I still speak in schools, and try and get people to think about this issue. So what does this all mean? Relationships matter. They matter a lot, you know? And it seems like such a simple thing to say, but sometimes when a risk factor is so around you, what happens is you don't see it. And I genuinely think that's kind of what we've done with HIV perceptions and risk. It's something that we kind of all take for granted. Interestingly enough, in the developing world literature, actually in the global health literature, there were tough statistics that showed this, that in some countries, for example, marriage was a risk factor. What do you even do with a statement like that, right? I mean, seriously, so do you stop getting married? You know, that's not the solution, but it makes you really grapple with the things that we usually don't talk about, or the assumptions we make. You know, in some cultures you can't say no to your husband, or in some cultures there's a disproportionate amount of violence. I'm actually working on a film right now, an amazing story about a woman in Ethiopia who got married too young and was abducted into marriage. There are situations in the world where vulnerable populations don't have as much choices. And so thinking through the context of relationships and the social conditions that actually produce risk is a great deal of what I do right now. I think the other important thing to think about is people always are making decisions. You know, humans are social. We make these important decisions actually about our relationships, our well-being within the context of these interpersonal relationships. And then it also begs a very disturbing question, which I kind of hinted at, which is, okay, if risk is the same across all, why are some people dying more? And, you know, that question is kind of the unanswered question in all of us. You know, you can't put everything in a film, but it's certainly the one that broke my heart the most. Because, as you know, in the film, I lose one of my patients. And, you know, we build this grand case. It's about all of us. But the truth is not all of us die. And delving into what leads to that disproportionate excess risk of death is something I've kind of devoted the next stage of my career to and to think about. By the way, this is supposed to be relatively informal, so if I say anything or you have questions, please feel free to stop me. I actually prefer interactive presentations as opposed to one-on-one, me talking at you. So that said, I want to talk a little bit about losing Tara Stanley, because that was the turning point for me as a physician, as a researcher, and it's also, I think, the fact that gets misrepresented most often, which is the HIV/AIDS mortality difference. So I wanted to review a couple of slides with you about that. So this is the mortality rates by race and ethnicity for women, and you'll notice the rate once again for black women is 25.7 as compared to a baseline of 1.2. This is 21 times as high. This is even more disproportionate than the slides I showed you about diagnosis and infection. Okay, so what this tells you that even in this day and age, now this slide is dated as of 2007, but even in this day and age when we have antiretroviral therapies, we have these clinics, there are portions of the population that are dying at extremely high rates that are just not tolerable. And thinking through why is, if I had more time, we could also delve into treatment disparities, because I think part of it is not everyone has the same kind of access. We legislate HIV medications on a state basis. I don't know if you guys have heard of ADAPS, AIDS Drug Assistance Programs, but a lot of states now have waiting lists for those kinds of things. And one of the things we know is if you have ADAP and access to medication, it actually ensures that you get on treatment. Valerie Stone's actually done great research on treatment disparities, but I think that's part of the story. So HIV/AIDS has higher mortality rates in minorities as a whole, and even in 2006, the death rate in African Americans was at least 10 times higher. So these next two slides just show you, this is again deaths of person for all total. So when you look at this, men and women combined, the rate is 31.3% as compared to 3.2%. And when you look at these trends in age-adjusted annual rates of death, this is kind of like the big picture. You see the same kind of line, the blue line. This one, I'm just realizing, I think my slides got changed. I'm like, oh, I'll go with it. My slides got changed. This is the difference by men and women. This just shows you the disproportionality, once again, based on race, on death rates. And this is a slide I was looking at. What's interesting about just thinking through differences in mortality rates is actually the regional variations, because what you'll notice, have you ever heard this tagline lately that's been, health is where we live, learn, and play? I mean, they say this a lot now to talk about social determinants, but this idea that your zip code actually determines more about your health than anything else, okay? And to me, that's been one of the biggest struggles when it comes to awareness. Communicating that is a very hard thing to do if you think about it. When you're doing individual risk counseling, how do you talk about that? Move out of your neighborhood? So I think that's actually the challenge of some of this data. But what this data shows you, if you look at the Northeast, South, and West, these are the death rates are the blue lines. It matters more for Black populations where they live. It depends more actually on the mortality rate difference. There's less variation. So if you look at these bars in the other regions, for other race groups, there actually is not as much difference. You see how different it is between the Northeast and the South for this blue line, and from the South and the West. So it matters even more. And we actually know that from literature, just even in the international context, that the more vulnerable you are, the more these social factors actually end up amplifying your risk and producing risk. And the same is true in the States, in the United States. So this gives you just overall, HIV, when you look at the numbers from 87 to 2006, it's been a leading cause of death, actually, in the top 10 for all populations when you look at the age by 25 to 44. So we have unintentional injury as the number one, cancer, number two, heart disease, suicide, number four. I want to pause there because I think the other hugely underaddressed, and this is the other thing that hit me over the head in the film that I didn't really get to delve into, is the issue of mental health. I think mental health, it's to a large degree what brought me to government, and it's definitely why I ended up at the VA, because I wanted to work on this issue and think about this issue. But it's a hugely underaddressed epidemic, and I actually think for the future of HIV prevention, one of the most important things we have to do is integrate mental health efforts. Because we already know when you start to delve into treatment disparities, for example, who takes ARVs or not, what some of the studies has shown is if someone has depression, we know for a fact they won't, or they take it less. So I think we have a couple of co-occurring epidemics going on, and it's very hard to tease some of this stuff out when you think about it. Violence, drug addiction, mental disorders and HIV are all jumbled up, certainly in the places where I've practiced, which is the South Bronx and Philly. And then the other thing we still have a long way to go with is homophobia. I think that's the other issue. In the adolescent clinic that I was working in Philadelphia, it was mostly, young men who have sex with men and black. It was a very different population from what I was taking care of in the Bronx, which was mostly women. And I was just, they broke my heart. So many people had been kicked out of their homes for coming out. And, once you're on the streets, it's an entirely different ballgame when it comes to risk. Much harder to protect yourself for a lot of reasons, not least of which are material, and we'll talk about kind of the resources and the, basic needs that people need to take care of first before they can sit down and think about health. Because although I've devoted my life to health, and although all of you guys, I'm sure, have an interest in health, what I have learned working with regular folks is they're not thinking about it often. So one of the things that makes prevention such a challenge is you have to sit there and try and increase people's thresholds, like try to make them see things that are not quite a problem yet. That's difficult with any behavior, let alone someone who's negotiating adolescence or someone who doesn't know, where their next meal is coming from, or if they have, shelter over their heads that night. So I think we have to be a lot more realistic when it comes to our awareness efforts. And lately I've been talking about, prevention is kind of about a tactile thing almost, and capturing people's imaginations, which is why I think all of us to a certain degree hit, right? I mean, it was just really trying to get people to understand this is a lot more than the didactic information we give you at the clinic. This is about your life and how you choose to live it and what terms the environment sometimes deals you. So that said, this statistic, when I started residency, this statistic bothered me. I was like, this is my age group. What is going on? Does no, what? And actually, the thing that disturbed me even more was I went to Montefiore, which is like this bastion for social justice and health, if anyone knows about it. It's had the oldest department of social medicine, and there were all of these HIV researchers. And I went to the top one. I was like, do you know this statistic? And she didn't. And that's when I paused. I said, okay, what's going on? What's going on? Now, when there are disparities like this, and there are millions of dollars we're pumping into a system, millions of research grants that you're doing, and we're still not going anywhere, you have to take a step back and say, okay, what are the obstacles? Something is creating a blind spot. I don't know what it is, but something has to be. Otherwise, how can, HIV's turning 30 in June 5th of 1981, June 5th, the first case got diagnosed in the MMWR. So we are crossing a threshold, but what do we have to show for it, And really grappling with this issue. How can it be the number one cause of death in this group? That's more than anything what led to the film All of Us. And I, at that point, had done a master's in medical anthropology, and I had looked at this same issue in Ethiopian women. I actually worked with the International Center for Research on Women and wonderful Ethiopian researchers at an institute called Ms. Hassab Research Center in Addis Ababa, and I did that on a Fulbright. And when I was in London doing this work, I was basically looking at HIV positive women's diaries. Okay, so my work was they had gone to Ethiopia and collected all of this data with HIV positive people's experiences. The data had been coded and coded, and I was dealing with like the text. What does it mean? And so I had written this dissertation, this thesis on this experience of being HIV positive in Ethiopia. And at the time I met a filmmaker named Emily Apt, who was in London with me. And, she approached me. She was like, look, your work lends itself so well to film. You should really consider it. Because I was looking at stories all day. Never really thought about it. But when I got back to the Bronx, so I decided to, at that point I came back, I finished medical school, and I told Dad, okay, I am going to residency. He had a slight heart attack because he thought I wasn't. But I did end up going to residency. She had returned to New York herself and was starting her own film company. And so that's how this partnership happened. And the reason why I stopped to pause and tell that story is because I think awareness in HIV is going to take a lot of unlikely partnerships, actually. And it's kind of one of the things as professionals that we are not trained to do so much. We do not know how to talk across disciplines very well. And when you start to kind of unpack why these numbers are what they are, or you go back to what I mentioned about obstruction analysis, what are creating blind spots, you realize there's actually a lot of silos that we all live in. I don't care what you do, we tend to think of it, and the more training you get, the more siloed your world gets, and you start to develop these blind spots. So I truly think one of the things we need to do is a lot of this interdisciplinary work. So, you know, at this point, I had come back from Ethiopia, but what I didn't realize at the time was that experience had given me very powerful vocabulary and a framework to start thinking through context. Okay, so I wanted to pause here and at least mention to you the global disparities, because when you look at the numbers, it's kind of humbling. You know, up until this point, we've been talking about this. Okay? This is data from the UN AIDS program. Now, all the slides and CDC data I've been talking about has been on less than 1 million people. When you take the epidemic and you start looking at it by country, this is sub-Saharan Africa. Okay? This is the line for 2002, 12.5 million people, and at that point, a number of women, 12.5 million women, and 13.5 by 2004. So I went from this experience with my master's work to thinking about it. But let me tell you, the determinants are actually not dissimilar. The determinants are actually very, very same. It's similar. It's just a question of magnitude. What HIV did on the African continent was just unmask the fact that there wasn't a public health infrastructure at all, you know, that there wasn't care. And when you look at the same kind of issues in urban centers, people are still not plugged into care. You know, it's just a question of magnitude. So in you know, in a kind of ironic way, thinking about that extreme setting, I personally think actually helped me see what was going on better in the South Bronx, and at least made me aware in a different way. So if these determinants are what it's about, and I fundamentally think what HIV teaches you more than anything is it tries to tell you this story about social determinants. Lately, we talk about this a lot. You know, the Robert Wood Johnson Foundation has done a lot of great work around developing language for social determinants. So this idea of where we live, learn, and play. Thinking through, okay, how do you communicate about this? But I think the other story it tells you is the story of access to care, right? The story of access to care. And this is certainly in the global epidemics, post-2000 and on, the whole movement of trying to get treatment to Africa and struggling with that was all about that story. This is a very difficult subject, though, I think, to communicate about one-on-one when you're talking about risk counseling. So, you know, although contextual influences determine health outcome, I don't think we've been quite as savvy about figuring out how to integrate that in our prevention messaging. So this slide is one attempt, and it captures our problem. How do you communicate about this web? I mean, seriously, look at it, right? This is a slide from one of my favorite nonprofits called Advocates for Youth. They produce great stuff. And this is their slide on understanding disparities in the HIV epidemic, how social and cultural forces lead to unequal risk for African Americans and Blacks. And for those of you who can't read, so what these buckets say, and we can really talk about each one of these for an entire presentation on their own, right? So mistrust of the healthcare system, delayed diagnosis and or treatment. I personally think this is very huge, actually. People still, we know from the WISE study, which is the Women's Interagency HIV study, it is our largest natural kind of history study of HIV infection in America. It's based on 6 different sites. We know from WISE that about 28% of women who meet criteria for treatment do not get it. Okay? Treatment disparities are huge. So delayed diagnosis is the other issue. A great deal of people still don't get tested. In fact, over half of the infections, I believe it was in 2007, were spread by people who were HIV positive and just didn't know it. So testing is still a huge issue. The CDC changed their recommendations a few years ago to make it a mandatory thing so we could mainstream it. So you go to your primary care doctor, you get tested, everybody once a year. The other buckets, unemployment and underemployment, right? People need material resources. People need economic security before they can start thinking about health. This is not a complicated science, right? The other boxes, so increased risk of HIV and STIs. One of the relationships we know is if you already have one sexually transmitted infection, it makes it easier to transmit HIV because you have, for women, you have vaginal shedding, sloughing. But so if you have undiagnosed STIs, that's another kind of baseline reason. If you're not accessed into care, if you're not plugged into care, more likely to have that. Unprotected sex, obviously, huge issue. I mean, condoms. But my problem with talking about unprotected sex, if we're going to talk about unprotected sex, we have to talk about domestic violence in the same sentence. And we do not make that distinction enough. On this slide, I think violence is one of these circles. If not, that's probably the one that I would put up the highest. And why I say that is, one of the things that blew me away in my research in the South Bronx, and I'm writing a book about all of this, I just needed time to think about it, is the alarming statistics around sexual assault. And at that point in my life, I had done a lot of public health work. I don't think it ever came up in my curriculum, ever. And I went to great institutions. The numbers in the United States, just so you're familiar with them. So this is why sometimes when people just leave this entire discussion about condoms and unprotected sex, I think it's irresponsible, actually. Because the truth of the matter is, on a population level in America, if you take the definition of child sexual abuse, which is penetration to molestation, it is 1 in 3 girls that have had this experience by the age of 18. 1 in 3. That is a huge population risk factor. And this number is not just black women. This number is across all races for women. It's also a number that holds substantially well when you look at the population variations between countries. So talking about unprotected sex without also saying, actually, for some women, it's just not a choice. They're forced, they're beat into it, they're raped. That's a very common reality. The other statistic to keep in mind is sexual assault in the context of interpersonal relationships. It's 1 in 4, okay? That's also alarmingly high. So 1 in 3 and 1 in 4, that's the reality of what a lot of these women are dealing with. And if you notice, for those of you who watched the film, that was Tara's story, right? I mean, that's what killed me. I just never thought about it, and in my own, thank God, naivete, but I haven't had that experience. And it's very hard to imagine, if you haven't had that experience, what that experience can mean. It's actually been studied. One of the researchers, when I made this film, I had a lot of, I decided who I got to interview. And one of the researchers was Gail Wyatt, who's a renowned researcher on domestic violence issues. And it's kind of why I wanted to talk to Gail in particular, was to help me understand what is it about risk. And in the film, she articulates it quite beautifully. She's like, we know what happens to women once they get raped. They tend to look like promiscuous women, or they tend to realize what Tara said was, I couldn't say no to my father, so how can I say no to other people? These are really heavy issues to try and unpack in any kind of way. And what we do in medicine often, or what we do in research, is we kind of leave it out of the sample or don't talk about it. And I think those are the different ways that we start to create silos and blind spots to the reality of what the epidemic is in these communities. As difficult as it is to confront those realities, we need to at least talk about them, because the good news is I actually think there's some things we can do. There are things to be done for traumatized patients, but you need to recognize that trauma is operating. So sorry to go on a soapbox on that issue, but I just think it's so important. It's so often ignored. And then the other boxes: drug and alcohol abuse, unstable neighborhoods, poverty, racism, historical and modern inequities, concurrent partnerships, one of my favorite terms in the literature, concurrent partnerships, people who are sleeping with multiple people at the same time. That's what that means. We do that a lot. Okay? And it's reality. Okay? It's a reality. And the irony, there's actually a wonderful book written by Dr. Epstein called, oh gosh, of course I'm blanking. This book came out a couple of years ago. Why the West is losing the fight against HIV or something like that on the continent. And she illustrates these beautiful studies on concurrent partnerships, especially in developing countries. And anyone want to wager a guess, why would it matter more there? Because one of the things that the literature has always shown is that, even though HIV/AIDS is more prevalent in Africa, it's not because Africans are having more sex than everyone. I mean, we know that's actually not the case. There's a lot of other issues around access, underdiagnosis of STIs, but importantly, also these casual relationships where people are having transactional sex for money, for security for their kids. One thing we know, women will do whatever they need to make sure their kids are fed. Those kind of realities are actually very common when you look at it on a population level across countries. So back to the original question you guys posed me, where are we now and what are the limits to awareness? How do you communicate about this in any kind of efficient way? How do you say, okay, we're going to allocate this many dollars to this web? An anthropologist in the 80s, Meryl Singer, developed a term called a syndemic, saying actually HIV has all of these synergies. It's not an epidemic, it's a syndemic. And in his analysis with substance abuse, violence in particular, and HIV were almost impossible to separate out. So it's a challenge to our funding system. Like if you think about how we allocate our dollars, how do you allocate risk like this? And that's the challenge. How do you even communicate about it? Even in the film, when you're telling these individual narratives of triumph, it has a tendency to slip into the individual responsibility trap too often sometimes. I mean, sure, there's a certain amount of responsibility that people need to have in terms of controlling what they can, but what happens when you literally have no control? What happens when you're in a situation like Tara was, where you're in an abusive relationship with no door out? And I think being modest about those limits for all of us is one of the take-home points. We can't put it all on condoms. We do that way too often. Condoms are a very important part, but it's a piece, and we need to remember that it's a piece. I think microbicides are huge, and thank God for the trials that came out of Venice that were done in South Africa. For those of you who aren't familiar with microbicides, what it is a chemical combination, usually a gel that women can insert in their vagina as a cream to protect them from HIV, so then the condom discussion is no longer even in the room. To me, that would be the sure shot way. Female-controlled prevention technology, we needed it yesterday, and there's been far too long of a delay. That's also part of the story. So a few thoughts on HIV youth, and I'm talking at you too much. Do you have any questions? Any questions at all? Yeah.
I would just like to say in the late 80s, advertisement was a key, especially with CDC, to educating, and I think that did help.
You're right.
The community at that time, and that may be why it went down, because of the education. But somehow, it didn't reach our community.
I agree with you. I think, and I'm glad you mentioned that. You set me up lovely for what I'm about to say about the youth. There are competitive messages in society that compete with what I'm trying to tell my patients in the office. And that we are being out-competed, bar none. I mean, to me, this is kind of the issue. People do not realize that, they leave my office and then they go back out into that world. They go back out into the South Bronx and they deal with abusive boyfriends, and they deal with, misogynistic images. They deal with all kinds of crazy situations. How do you compete with that? And I used to always say, the environment is, really kicking our butts right now, to tell you the truth. That's why one of the things that at least the Black AIDS Institute is actually doing, I think, some of the most cutting edge work around this issue in particular. They actually have a campaign right now called We Are Greater Than AIDS, greaterthan.org. You should go to it. You should check it out, greaterthan.org. It was a partnership with the Kaiser Family Foundation. They launched it towards the end of last year, but, you know, it's been running, and this is really trying to get back to your point of this issue of educating the community, especially the Black community, in ways that are positive, messages that are embracing. Why all of us worked is we were talking about love. You know, how common, the 4-letter word that you will never hear at an HIV technical meeting, unless I'm speaking. I promise you. That's my opening line all the time. Can we say the word, you guys? Love. It's a 4-letter word that doctors are very uncomfortable to deal with. Researchers even more so, because, you know, we equate emotions with irrationality.
But that's part of the person, and you have to deal with the whole person.
That's right. That's right. But honestly, we are trained, and I mean, I'm in the middle of a PhD, believe it or not, but we are trained to think that stuff out. It's part of why I love anthropology so much. It was the only discipline where I could leave it in legitimately and not worry about being called, you know, whatever by other people. It was a big enough discipline, and it's very intolerant of boundaries, which I love. So, yeah.
I was going to tell you, I have had some experience with some young middle schoolers
Mhm.
some years ago, and I talked to some police officers too. They were working in some of the schools, and one of the police officers, female police officers, was telling me about the rampage of a lot of lesbian activity amongst young kids,
Mhm.
13, 14, 15 years old,
Mhm.
experimentation.
Mhm.
And I said, well, what were they telling you? Why were they telling you that they were having these experiences in school? I couldn't conceive of it.
Mhm.
And she was saying that the young Black males, a lot of them were being locked up, being incarcerated for drugs
Mhm.
and other
Mhm.
activities and all, you know,
Mhm.
car theft
Mhm.
and things.
Mhm.
And that it seemed like there just weren't that many men, young men.
Eligible men. Mhm.
And then they were coming back. Then they were experimenting back and forth with the young girls,
Mhm.
and then having sex with the young fellas too.
Mhm.
And a lot of it too, they were saying there just weren't that many young Black men
Mhm.
around
Mhm.
their age.
Yeah.
They were still in school.
Yeah.
And then I said all this back and forth, and then I talked to another. She was my young sister-in-law, and I couldn't conceive of her, but I talked to her, and she was having a continuous affair with this young woman.
Mhm.
But then when the boyfriend came out of jail, she was having sex with him as well, and I just was so worried about her. I kept trying to tell her, you know, anything can happen.
Yeah. I hear the mom in you.
The violence, the
Mhm.
violence with the boyfriend coming back,
Mhm.
seeing, and I said, why are you still having this affair with this young woman? She was around the same age, maybe 19, 20.
Mm.
She said, well, she works. She's very, she gives me a lot of, shows me a lot of love
Mhm.
and attention to my daughter,
Mhm.
the daughter by the
Yeah.
fellow
Right.
officer Jay.
Right.
And I said, but when he comes out and he beats you up, the police are constantly being called in, what's going on?
Right.
And she said, well, because I love him and he's my daughter's father.
Mhm.
Just couldn't conceive of it.
Yeah. No, it's hard to wrap your head around. You were right.
She was in this high school, right here, Eastern High
Mhm.
School, right out here in Southeast, and she was telling me, she said at least 50% of the girls are having sex with either boys or with
Mhm.
other
Mhm.
young women. So I think a large part of that and they may already be doing it, except the kids need to be reached at that level.
Oh, absolutely.
You know, and then
I mean,
you talk about
literally.
sustaining and it, like you mentioned, love.
Yeah.
What is the true meaning of love?
Yeah.
And
Yeah, we need an emotional curriculum with this stuff. You know, it's funny. We leave it, we get educations and everything else, and then we kind of pretend to figure this part out, and it doesn't always work, you know? It doesn't always work. You touched on 2 points that I talk about in the film. This issue of sex ratios is real in the Black community in terms of incarceration is the other soapbox I usually get on in addition to violence. What incarceration did in Black America was create single-family homes. Okay, We've created single family homes and we've maintained it. And what happens is sexual networks change when you do that. We know for a fact that that happens. So it's another contextual influence that's as important, as far as I'm concerned, to think about in terms of producing what produces risk in these populations, you know. So when you have single people who are not in marriages, we know they tend to have sex with more people. You know, if you're in a monogamous marriage situation, you tend to hopefully stay with your partner more likely than not. Sometimes that's not the case either, but the point is, we already know. So that's where the incarceration piece, the other piece that incarceration does is, you know, people get raped in jail. Lots of things happen in jail. We already know that the HIV prevalence rates in jails are much higher than the normal community. And in a lot of places like where I was, you know, in the Bronx, you know, Rikers, there was a whole door out of Rikers Island and then back to the South Bronx and then back to Rikers Island. And so that's in of itself another cycle in a lot of these communities that creates those hotbeds. Remember that regional map that I was showing? New York, actually did this beautiful study where they overlapped the top boroughs of incarceration with the HIV map, and it was almost a 1-to-1 fit in terms of, you know, maintaining the odds of infections in those populations. So, I mean, how do you communicate about that one? How do you take on that one? So let me get through a couple of these slides. And, you know, the challenging questions to think about with kids and with young people is, how do you prevent new infections when you don't even know you're at risk? So this idea of, you know, young people are invincible. And, you know, part of adolescent development is I am invincible. That is literally part of the kind of psychological trajectory that you're doing. So trying to message around or trying to get them to think about vulnerability is a difficult thing to do at that stage. And this idea of competing messages that, you know, how do you sustain a behavioral effect? So even if you've given them the counseling, even if they've gone through the trainings and they've gone through the workshops, how do you maintain that effect in an environment that is difficult? I think a couple of the things you have to do, obviously talking about healthy relationships, what they mean, and I think the most important one, starting with yourself first. You know, having this discussion, it's really actually interesting. The teen pregnancy literature is fascinating, and the things that we've learned, you know, sometimes I don't even think we should call it sex education. It's actually knowing yourself education, for lack of a better word, because some of the things that we know that delay pregnancy or delay sexual debut, you know, how the age at which you first try, are things like public service at a young age. Who would have thought? Or things like, for girls, being involved in team sports. Or, you know, the other, school attachment, how proud you feel about your school, how connected you feel about an identity outside of the one society gives you. These are very tricky things to try and wrap our head around, yet when we think about sex education, we don't look at that literature, we kind of boil it down to abstinence, or are we talking about sex? And sometimes, really, it's about age-appropriate information about development and who you are. So I almost feel like we need to kind of repackage what we're talking about. I think, once again, addressing dating violence and sexual assault is huge. Dealing with mental health, you know, issues of beauty, eating disorders, all of these things are kind of rolled up in one ball when you're dealing with adolescents. They're going through a lot of this stuff. And then last but not least, behavioral communication skills. You know, verbal art is what I call it. You need to learn how to command yourself through words. Because oftentimes when you think about how all of this discrimination happens, how power balancing happens, all of these things revolve around censorship and how you censor yourself without necessarily even knowing it. Failing to articulate your own story so someone else does it better than you, and you kind of go with that script. So I think communications is actually a huge piece of this story as well. The other things to think about, you know, youth by definition are at risk for a longer period of time. So the interventions that we have to be even more robust, offered in even more voices, offered in even more places, just because of the time variable. The social environment, as I was saying, in adolescents' lives is a hugely competitive force. How do you create health-seeking behaviors in that kind of setting, especially when it's out-competing you? This next slide is one way to think through it. You know, if the kid is in the middle, thinking through these more, you know, what I call mainstreaming prevention is about thinking what touch points people have in their lives. Young people come across all kinds of touch points, right? I mean, they have families, peers, which is kind of their enablers that sets influences around kind of social conditions. But, you know, teachers, police departments, someone mentioned, huge unused population as far as I'm concerned. I've actually given HIV and domestic HIV trainings to police cops, and they're so receptive in a way that I had never imagined that they would be. I think the other group we ignore are parents. I've had so many fathers reach out to me, so many mothers reach out to me, say, look, I know I'm missing this point. How do we do this better? I think it's a hugely underused population, largely because people assume no one wants that they wouldn't go there, but actually I think they would. Providers, the court systems, guidance counselors, these are the kind of places that we actually need to offload our discussions of HIV risk to. I mean, they can come to me anytime as a doctor. They can come to their primary care providers, whoever they are, but actually these people see them much more often than I do. And that's just the reality of the situation. So thinking through what we have to do to offload some of this discussion, and some great work is being done on the city level. In Philly, there were great community-based programs. The question is scale, right? How do you take something from a city level and then move it up, kind of getting it in the water? Much harder issue to tackle. And then employers, I love occupational health lately because it's a really interesting space. It's another interesting space to think through how to broaden this discussion about health and how to create ownership about it. As we go through, the implementation of our, huge healthcare reform legislation, occupational health and wellness is a huge part of it. People spend a lot of time at work and therefore you kind of got to meet people where they are at. It's actually a very powerful site to think through what behavior reduction, even behavior change, can look like. There's a lot of behavioral wellness type initiatives that are now being funded, wellness at work initiatives. This is part of the continuum for HIV risk reduction because I really think it starts here, right? Although we make this debate about sex, we make it about all of this, it starts here. It starts with you, your relationship with yourself, conversations about worth, what your limits are, what your boundaries are. And that kind of discussion is an emotional health discussion. It's an internal one that you have to start sooner. I think these are the other oh, there was a hand. Go ahead.
That's the takeaway that I got from watching all of us when you took what was happening, because you may not be able to identify with your case studies.
Yeah.
When you had that meeting at the home with your sister friend.
Yeah.
And talked about their emotional dealings with relationships and flipping that emotional dynamic of unprotected sex means love.
Mm-hmm.
And because that went home to me, and
Mm-hmm.
I went and talk to my girlfriends about that, because we do that. Do you always use condoms?
Mm-hmm.
And do you automatically think, oh, he loves me
Mm-hmm.
because he didn't use protection?
Mm-hmm.
And you have to love yourself and say, I'm going to protect myself.
That's right. That's right. And if you notice, those are really my friends, and I said it in the film, very privileged, very educated women. And it really boils down to kind of, have you stopped to think about it? That's why I think even what you said about pulling her aside and saying, wait a minute, why? That starts the journey, So sometimes a lot of this stuff is so basic that we just miss it and we don't give ourselves the time or space. I think the best HIV risk reduction counseling happens with your friends, hands down, bar none. They know you like no one else, so their meters are a lot higher. You can't lie to them in the same kind of ways. You feel comfortable enough to share what you are doing. As a doc, even, try to be very extra nice. People, there's a power dynamic there. People don't always share. Even, with Tara, it took her a while to trust me enough, to do that. Trust takes time to build, but there's a lot of relationships that already have it. Which is also why I think the other part, very powerful part, is in the film, when I go into the schools with Chevelle's imparting wisdom to those girls was talk to your mother. How often do you hear that for an HIV prevention message? Have you ever heard that actually? And it's so true. I actually think health starts at home. It starts at home. And there's actually a lot of disturbing literature that I didn't have time to go into. It depresses me, so I don't present it often. But the ACE studies, adverse childhood event studies, if you have time, go over this literature. It's disturbing how much gets determined between 0 and 5 in terms of your life outcomes, how much you've seen, the stressors, and the more adverse events you have, the more correlation you have with chronic diseases later on, poor health making decisions, so much gets determined at home first. So having those conversations with your siblings or your parents is actually a very productive space that we often don't use. So the other thing to think about, youth service organizations. This is an easy place to mainstream HIV awareness efforts. There's actually a lot that are already doing it. I worked with one in Philadelphia that I loved. Very, very low-hanging fruit that I think we can do. Working with schools and college campuses. I teach at GW. There's tons of student groups there that are constantly looking for activities. I think that's another easy place to mainstream awareness and take it outside of doctors' offices. Obviously, primary care providers, to the degree that we can make HIV a routine thing, not necessarily a stigmatized disease or activity, which has been its history for a very long time. And then targeting young people who've dropped out. Once you drop out of school, a lot of things get determined for you. A lot. And I really didn't appreciate that enough either, or think through that enough until I started seeing what was happening to some of the kids I was taking care of in Philadelphia. So these are leveraged touch points. These are places where HIV awareness is not happening enough, or is low-hanging fruit as far as I'm concerned for taking HIV awareness to a larger scale. So the future, a couple of words about the future. So what does this all mean? I've told you a story about context. And as an anthropologist, that's actually what I study. How do social influences, how does culture, how do the conditions, the milieu that we live every day determine what happens to us? In addition, obviously, to the structural things, like where you live and what you have access to. This is actually a quote from a very wonderful physician who was the leader of the health and human rights, really the founder of the health and human rights movement, Jonathan Mann, who is no longer with us, passed away, but I had the good fortune of actually having him as a college professor. It kind of changed my life at a very young age. But one of the things he would teach is that, public health's difficulty in addressing the indisputably predominant social determinants of health status is exacerbated by a lack of a coherent conceptual framework for analyzing social factors, societal factors that are relevant to health. The social class approach, while useful, is clearly insufficient. Public health action based on social class is often simply accusatory, and it raises but cannot answer the question, what must be done? In this sense, poverty as a root cause of ill health is both evident and paralyzing to further thought and action. I wanted to at least end with this because I think, finding this language about how to talk about actions has everything to do with social barriers. Health disparities, not only HIV ones, are kind of inextricably linked with social barriers. These barriers include violence, discrimination based on sex, race, gender, and or sexual orientation, stable housing, really should have said unstable housing, unequal access to care, unemployment, economic disempowerment, and poor education. This is the milieu of social barriers that most people face in their lives, and this is what contributes to health disparities. So what barriers do is they increase vulnerability. They keep people even more vulnerable. And what I've learned is there are limits to vulnerability. This is a definition also by Jonathan Mann and Daniel Tarantola from a book called AIDS in the World too. And it says, vulnerability is the converse concept of empowerment. By vulnerability, we mean the extent to which individuals are capable of making and affecting free and informed decisions about your life. So living your life on your terms. A person who's genuinely able to make free and informed decisions is least vulnerable, empowered. The person who's ill-informed or does not have the ability to make informed decisions freely and carry them out is the most vulnerable. And where we are now in 2011 is not that dissimilar from where we were many years ago in the epidemic. The most vulnerable are the ones that get hit with social barriers the hardest. And until we can fix that equation, we're not getting anywhere. I think part of what confronting social barriers means, and I alluded to this earlier, is it requires thinking out of the box. It really requires interdisciplinary approaches, unlikely partnerships in leadership, and social entrepreneurship. Each one of these are presentations in of themselves, but I think examples that I've talked to you about and thought through. I continue to use film. I think it's a wonderful medium to try and teach people and reach people. I mean, this film was aired on Showtime for 2 years, and I can't tell you. I couldn't respond enough to people fast enough. I still have a long list, but what I walked away with is, okay, it's in the water. And I think we need more efforts like that. I'm still a researcher. I don't think of myself actually as a filmmaker. I think of myself as a public health researcher and a physician. I just use it. It's a tool for me. And so right now I'm working on a film, 2 films, one on race in America called Outside the Box, the second one on violence in Ethiopia and women's lives called Oblivion. And I continue to encourage scholars and educators and anyone who's really interested in teaching people meeting people where they're at to use films and use kind of these innovative health literacy efforts through media. I think the other things we can do, which I've talked to you about, is offloading health into the places where it actually happens. So communities, schools, workplaces, even conversations like this, like right now, what we're doing right now, if we could do this more often at a more regular interval, you would be surprised at what happens, right? These small changes add up. You can start to accrue scale. Because remember that main theme of what I was saying, societal, there's a lot of competitive forces, right? The messages that we try and impart to the people we're teaching gets drowned out by all these other voices. So to the degree that you can start to build up some a saturation model where some of this stuff gets repeated over and over again, I think it would do a lot of good. I also really think health starts at home. So thinking through how to use parents a lot more effectively than we have. I know I've met many wonderful parents through this whole initiative, and it's actually something that my nonprofit is actually thinking a lot about. Okay, what can we create for parents that makes it all a little easier? The other thing is we need new messengers. She was the woman who introduced me was joking about my age, and at this point I'm like, shoot, we need people like half my age. We need people even younger. We need to recruit new messengers. They do not have enough opportunities. Young people do not have enough opportunities to teach us. And you would be humbled if you gave them a chance. It's something that I've learned over and over again. There's actually an overwhelming talent brewing. There's a lot of HIV educators that are very young, very articulate that I've met. And if we could just give them a stage and get out of their way a little, I think it would be wonderful. And I think they're the most effective at talking to their own peers about these messages. So we need a lot more messengers. You don't have to be a doctor. You don't have to be HIV positive to talk about HIV. Right. And I think people need to be comfortable enough to own that. The epidemic, the activism and advocacy around HIV very much came out of the leadership out of HIV positive people. And I think that's wonderful. And they continue to be a very important voice. But I think there's room for other voices. And I think it's important for people to take on this battle, even if they are not positive. Chances are, with the numbers being what they are, I'm sure someone in your life is, The other thing is the difficult conversations, to your point. The woman who spoke in the front row, stopping someone and saying, wait a minute, what was that about in your own peer circle? You obviously have to have these relationships and feel comfortable enough to do it. But, challenging difficult conversations take a bit of courage. They take, some courage, and that's what we need. They're also uncomfortable.
I think this is so good that you're here and you're educating us, but the information that you're giving us and through the questions and comments that other people have made, we can go back. It may be a small circle of people that we know, but we'll share it with those people, and those people will share it with more people, and that's what has started to take down the ugly face of AIDS. And I don't want to talk about it, and put it in the corner somewhere and hide it away, when it really needs to be right there in front of our face.
Yeah.
So we can face it and move on.
And thank you for saying that. And I think I have one more slide. I thought I was at the end. I just wanted to pause. There's some great things that have happened. Leadership is the other thing we need for confronting social disparities. I mean, America finally has a national AIDS strategy. This is so huge. You guys, we haven't had one forever. So we finally released the National HIV AIDS strategy last year. And if you haven't read it, read it. There's a role for you in it. It's online, AIDS.gov. The other thing that HHS just released last week, which was huge, is the federal government's first ever plan to eliminate health disparities. We have never done this before. This got released 2 weeks ago. That's also on the website. It's called the National Partnership for Action. I sit on the Federal Health Interagency Health Equity Team. Very, very exciting things that are happening, and really room for involvement from people who want to get involved. So I wanted to leave you with that, and that's it. So thank you for inviting me. If there's any questions.
This has been a presentation of the Library of Congress. Visit us at loc.gov.